The roosters, good morning. Good morning. It's a beautiful sunny day. Well, here you are listening to a report about a gloomy topic, but still relevant for many. Now the floor is yours. Okay, so go click it. So actually, we probably should start with the following. Whenever we talk about interpretation in a highly specialized topic, there's an endless discussion. Who should be interpreting? A linguist, a professional interpreter, or a specialist, say a doctor in this sphere? Because a doctor might be an expert in the field, but not so good with interpreting, and the interpreter is not an expert. So the opinions differ, but we have figured out that there is something in common. And essentially this quotation, this video clip, presents our opinion. The person has to be, well, human and be able to think. Well, that was unexpected, the video is upside down, but the point is, we think that interpretation skill would not depend on the certificate. It doesn't matter whether you have a certificate of an interpreter or a certificate of the expert in the field. That is not important. For simultaneous interpretation, you should have this biological skill, the ability to split attention into several channels, the ability to perceive without probably some conscious effort of the cortex, and to process it and to deliver this in a different language. I think this is just a peculiarity of the brain structure. It's not something you get only in the cortex. I tried this myself. I can perceive, but as soon as I start delivering language, I stop perceiving. So I think only a few have this sexual biological skill. That is why we think that any person who is able to think can figure out how to do it. It doesn't make sense to go into a narrow specialization unless you like it. That's why you have to enjoy your field, and you have to live enjoying. So, work in medical interpretations. If we talk about medical translations, it's quite clear. We have leaflets, inserts, we have patient charts, we have medical tourism, when a lot of patients want to travel abroad and the doctors need to know the information. But what about medical interpretation? In Ukraine, unfortunately, we don't have the system of community interpreting. If a patient ends up in a hospital, they kind of are not entitled for a free medical interpreter. But still, in Ukraine, we have specialized medical conferences on different topics with international visitors. Also, we have medical equipment presentations, workshops, as professional development for doctors. Sometimes it's international experts coming to Ukraine and teaching here, or Ukrainian doctors going abroad and training there. And of course, clinical trials. There are a lot of trials run in Ukraine, and many of them happen in oncology, and they get audited. So some person responsible comes here and checks all the papers, if they're filled in correctly, if everything goes well. And of course, interpreters are often needed in that process. Also, a small note: Ukraine is very active in clinical trials. So the density of clinical trials in Ukraine actually is lower than in Poland. But yeah, we try to promote it and we try to develop the field. There's another myth, well, or semi-myth, that doctors do not need interpretation at conferences or specialized events, because all modern medical terminology is English anyway. They're supposed to be able to read English, so they shouldn't require interpretation. And this is partly true. Many skilled, high qualified specialists do understand English, but still it's easier to perceive the information in your mother tongue. And this information has to be adequate. It has to be reasonable. It has to be what the speaker is trying to broadcast. And, well, this myth is caused by the fact that Ukrainian doctors are not really frequent visitors on medical conferences with interpretation. And they might come to this event a few times a year, and they have heard some bad interpretation, and then they think, okay, I don't really need this because I had this bad experience, I had the rubbish in my headphones, and that's why I don't want it. The point is, the interpretation has to be really accurate. It has to clearly deliver what the speaker is trying to explain. That's why high-quality interpretation still is required. And, of course, we cannot interpret everything. From my own experience, from the requests I receive, and from the work of my colleagues, I can say that the most popular topic in medical interpretation is oncology. It's hematology, also as an adjacent field. On cardiology, there are also a lot of events. Dentistry, including aesthetic dentistry. Another frequent topic is aesthetic surgery and plastic surgery. There are big congresses on that, and infectious diseases. Well, this year, the terms like viral load essentially is a notion that everybody now understands. So, and epidemiology, of course. Of course, just like doctors don't specialize in all the fields of medicine, because each particular field has a ton of knowledge. So doctors specialize, and interpreters probably do the same. So medical interpreters they master this or that field better out of the general domain of medicine. And it's totally fine. It's like a junior doctor. When they go out to the market, they are trying to figure out what their specialization would be. Same is for the interpreters. They look into their preferences, what brings them more fun and interest, and then essentially they choose their specialization inside the domain of medicine. So, as we said, we specialize in oncology. That is why we will look into that particular beast and what's it made of. First, we have the stage of diagnostics. When the patient is diagnosed, and in oncology, it is a set of different methods. They are applied comprehensively, but this is radiology, which is MRI, CT, X-ray, and so on. And there is a whole different set of terminology there. And it's not our strong side as well. I deal with lab methodology, like pathology, molecular pathology, and we will dive into that particular aspect more. To start, we want to give you an interesting case for the interpreters. The English term pathology has no direct equivalent neither in Russian nor in Ukrainian. Pathology comprises three different fields: cytopathology, histopathology, and molecular pathology, which have different names in Russian, which they can be rendered in English as cytology, histology, or molecular pathology, but we don't have native Russian terms or Ukrainian terms. Historically, we had these histological terms. They were there before. So molecular diagnostics joined later, at a later stage. That is why molecular pathology as a separate field, a separate direction, only formed like 10 years ago, or less than 20 years ago. As Ukraine, is slightly lagging behind about a dozen years in every industry, there was the same in this here. In terms of post-Soviet mentality, the term pathology was more or less equal histology plus more or less cytology, cytopathology, and maybe a little bit of molecular methods. While in the Western world of diagnostics, these three major fields are equal and they help each other and they make a comprehensive system. So let's go section by section. Cytopathology. This is studying cells, and it is subdivided into gynecological and non-gynecological. Many of us know about gynecological cytopathology because women of a certain age undergo the pap test, which might find possible anomalies in the reproductive system. But once again, medical traditions are different in different cultures. If in Ukraine this is kind of chaotic process, a cytopathologist is looking into that, and in Western countries, the process of this screening is more systematic. The lab, which receives all the samples, has two dedicated positions. There is the cytoscreener, who only looks what is normal, what is abnormal, and everything abnormal then is given to a cytopathologist. And in Ukraine, these two specializations merge into one. Well, why do we have this differentiation into the gynecological and non-gynecological? Because essentially the most part, the biggest chunk, is the cervical screening. That's why it's called gynecological. And everything else, like the punctures of the mammary glands, of their sites, some other secretions, all that is tested in this non-gynecological cytopathology. And if we talk about the screening, the most important is to separate good and evil, to look what is benign, what is malignant. And also in cytopathological methods, we look at cells, not in the context of the bigger tissues, but we look at cells specifically. That is why sometimes it's not so easy to divide into benign and malignant. And that is why also borderline tumors are not so easy to find. Actually, that slide, if anybody was wondering, was the thyroid carcinoma, which is a malignant tumor. Next, we have histopathology. This is studying not cells, but tissues. And here also we have differences in the names of the positions. In the English, it's called just a pathologist, while in Ukraine we have what we can render into English as a histologist, a pathomorphologist, and we still have this Soviet classification where the official position of the doctor is rendered into English as pathological anatomist. It's just a historic notion. And many people still perceive that that a pathologist, this pathanatomist, is doing post-mortem. But actually, it's the opposite. The biggest part of our job is just lab work, when we do biopsies. Biopsies essentially is when you pick a small sample of the tissue, you put it under the microscope, and then you try to figure out what the disease is. Or post-surgical study, when they want to look into the tumor, what the stage of the tumor is, and what is the condition of the lymph nodes, what is the stage of the disease. And then the final diagnosis is given, and on the basis of this pathological diagnosis, then the stage of the disease is figured out, and the treatment is chosen. Another part of histopathology is immunohistochemistry. Of course, it's a long title, that's why usually it's abbreviated as IHC. But the person involved in this, it is also called a pathology. We don't call them immunohistochemists. Or sometimes in English they just say immuno. We did some immuno. They mean IHC, essentially. So this thing emerged in 1980s. Essentially, it is a molecular method. This is a way to find different proteins in tissues. So immunohistochemistry means finding specific proteins in tissues. Mostly, this is required to specify the diagnosis, because the tumors could be very look-alike, but they could have different origins. And then they would be sensitive to different types of therapy. That is why that is the method to specify the diagnosis, or if we know that this is, for example, breast cancer, we still use this method to check the hormonal status to figure out if the patient can be cured with say hormonal therapy. So it has both diagnostic and theranostic significance. Yeah, so now we are at molecular pathology. And unfortunately, the term in Russian or in Ukrainian is not yet widespread. The guys who do that could be called a geneticist, a molecular biologist, which, yeah, it's partly true, but it does not reflect the essence of the term. Why do we need this specialization? Well, the most interesting thing is finding hereditary cancers. If your relative had an oncological disease, had a tumor, then depending on certain tests, you or certain characteristics, you can figure out if the chance of hereditary cancer is high or not. And in this case, the germline mutations are tested. Yeah, so these molecular biologists or geneticists, they can actually work in agrochemistry, in agricultural field, or in forensics. So the term molecular biology is very wide. That is why we have this narrow definition. People who do molecular diagnostics in oncology are called molecular pathologists. In Ukraine, we still are quite far from that understanding. So besides figuring out the hereditary predisposition to the development of cancer, which is important because we can know the risk. If the risk is high, you can create some screening schedule, you can try to mitigate the risk. But also, this specialization is used to to clarify the diagnosis. For example, in the situations of lymphomas and sarcomas, other methods like immunohistochemistry do not help us to differentiate the diagnostics, while molecular pathology can find a certain translocation and tell specifically what the disease is. And another big subsection, and there are many conferences on that, is what in the Western world is called Theranostics, which is finding specific genetic changes in the tumor which affect the choice of therapy. Mostly this is to choose the target therapy or immunotherapy. Now this field is being developed massively. And previously they were looking for specific isolated mutations in certain genes. Now we have big panels of genes, and the interpretation of the test is more and more complex and kind of difficult. So it's quite a big new field that I am now exploring and developing. Now, a few words about the methods. When we talk about cytology, immunohistochemistry, well, they all are different. Like a cytopathological, that's one method, IHC is a different method, but different methods, and molecular pathology has different methods. There's a whole variety. One of the most widespread is the so-called FISH, the fluorescent in situ hybridization. So there's a certain marker, very specific to some sections of the DNA, and you can figure out that a certain gene has less copies than normal, or there are some changes, some movements of these bits. Here there are, like, the important terms are amplification, for example, when there are several copies of a specific gene instead of one, or a deletion when the gene is no longer there, or the translocation. In English, there are two different terms, translocation and fusion. This is and this means the translocation of a segment of the chromosome into a different section or into a different chromosome. Unfortunately, in Russian or in Ukrainian, they all are rendered as what we call translocation. Essentially, when a segment is translocated to a different part of the gene, it creates a kind of a chimeric thing when a gene is mixed. And when the RNA is creating this protein, it looks like, you know, half fish, half cow. So it's like a chimera. And that's why it's called fused. But, well, unfortunately, in the Russian language literature, this term is not widely used. It's understood, but strangely, they just put into this big pool of translocation. And yeah, I also follow that trend. When I speak, I just use the word translocation. And when we talk about amplification or deletion, in the English literature, you can see that that method is intended to identify copy number variation. So amplification or deletion essentially means the variation in the number of copies of that gene. Another set of methods, the PCR or sequencing methods. We don't have just one PCR method or one sequencing method. There's a whole subset of different PCR methods or different sequencing methods. Now, mostly we have real-time PCR and the next generation sequencing. And this, of course, also is a set of different methods, but they are grouped into this term next generation sequencing, even though they even have different principles. Yeah, by now I'm sure everybody knows this abbreviation of PCR because it's used to detect COVID-19. Well, this method is used in oncology as well. And if we talk about the oncology, mostly sequencing is used to detect single nucleotide polymorphisms. What does that mean? And it's pronounced usually as SNP. Now we have the human genome decoded. We know that our DNA is a long sequence of only 4 nucleotides, A, G, T, C. Here they are at Dima's t-shirts. And we know that it can be like A, G, D, T, C, C, and so on. And sometimes where there should be A, there's G. This is polymorphism, single nucleotide polymorphism. It's quite a frequent phenomenon, and usually it's a neutral thing. It's not significant. If it's not significant, we call it polymorphism. There are cases when there are dire consequences, and then it's a bad polymorphism, and then we call it a mutation. Yeah, but we actually all are different because we have different variants, different versions of same genes, and then genotypical variation leads to phenotypical variations, which means that we all look differently. And if it's something bad, we call it a mutation. If it's neutral or good, we call it polymorphism. Okay, so getting back to oncology and to what we find with these methods in oncology. When we say cancer, this term, it includes all types of diseases, and even in the West they call it just cancer. But the valid use of the term cancer is there only for epithelial tumors, and they can be benign, and then it's called an adenome or fibroadenome or like prostate adenome. So if you hear the word adenome, then it's benign. If it's carcinome, then it means that it's malignant epithelial cells. Yeah, we're not showing any pictures to you because it still is a lovely morning. Now to continue.
So basically we have adenocarcinoma from the glandular epithelium. Glandular cancer is the old term. We no longer use it, but it's correct. And there is also squamous cell carcinoma that stems from squamous epithelium. Squamous is not literally named in Russian term. The next group of tumors is lymphomas. We can hear it named lymph node cancer. Why? Because certain lymph nodes are enlarged, or a subset of nodes that are affected. Actually, that's not cancer per se. This is a tumor stemming from lymphocytes. That's why they are called lymphomas. And they are basically divided on the basis of cytology or cytopathology. First, they were described, and first the diagnostic criteria for lymphomas were set for Hodgkin's lymphoma. All other types of lymphomas are called non-Hodgkin's lymphoma. There are dozens of these other lymphomas. So basically speaking, non-Hodgkin's lymphoma is a challenge for translation because there are so many of them. For example, mantle cell lymphoma or DLBCL, which stands for diffuse large B-cell lymphoma. No one uses its full name. Basically, we always hear and see acronyms only because it's so difficult to pronounce. Oncohematology is something which is really complex. So many various diseases belong to this area or niche of medicine and basically oncology. Whenever you get a request for oncohematology, be careful. When we have local conferences here in Ukraine, it might be a little bit easier, whereas when we deal with the foreign conferences where everyone speaks in English, it's really complex because it's always based on molecular biology. I myself do not know everything related to this area. By the way, I have done recently an assignment in oncohematology. It was really challenging for me. The next subset of tumors are also quite common in terms of prevalence and incidence. I mean sarcomas. They belong to mesenchymal tumors, or they might be called soft tissue tumors. And there is a small paradox here. Soft tissue and bone tissue can be affected by these types of tumors. So you see this division on the screen. These tumors can also be both benign and malignant. When they are benign, they are called fibroma or myoma. When they are sarcomas, they can be of different subtypes. For example, bone tissue, it's osteosarcoma, and so on. We talked about localization or the place where the tumor is in the body. Now let's move on to another classification based on the histology or histological classification. So we see high-grade tumors, low-grade tumors, and be careful, we have large cell, small cell tumors and non-small cell tumors. You see the abbreviation NSCLC. The lung cancer is one of the most common cancers, and that's why you see this abbreviation quite often. So large cell, small cell, clear cell, and germ cell tumors are also other types, examples of histological classification types. Do you all agree that everything is quite logical here on this screen? Look at the left-hand column. High-grade tumor is translated as low differentiation tumor, actually. Can you feel the paradox? The simultaneous interpreters specializing in this medical topic are already engaged at the moment, so they are not able to reply. Look, high-grade tumor means that we are talking about the level of malignancy. It means this high, this word high means that it's really malignant, very malignant. And low differentiation means it does not have properties of the cells from which this tumor is stemming. It's so changed, the cells have been changed so much they are barely recognized. And this is an example of how difficult and challenging it might be for a translator or interpreter to find the proper equivalent, because it's not very intuitive sometimes. Let's move on to staging. Once we have identified histopathological diagnosis, we have to identify or define the stage of the process. What's important for us, the interpreters or translators, is as follows. We often see case studies during the conferences, like male, 65, type of carcinoma or cancer, and later we see these combinations, TNM classification. What does the T stand for? Easy, it's tumor, and usually they put the figure in front of it, which means the size of the tumor. We sometimes see TIS, which means tumor in situ. We do not translate it. The next letter, N, stands for node, lymph node, basically. It means that there is a regional lymph node closest to the tumor, and we define whether it's affected by the lesion. Third letter, metastasis, denotes actually metastasis, and we see whether we have them or do not have, and depending on that we see the figure next to this letter, 0 up to number of metastases. We often see some organs and it's always defined by the anatomy of our body. It's really important that you revise the topological anatomy before you go to the assignment, so that you can name all the adjacent bodies or regional lymph nodes, especially when you deal with the intestine, small intestine, large intestine. There are a lot of lymph nodes around the intestine, and molecular biologists always are very specific about the nodes they are dealing with. And again, here you might face some terminology, translation of which is not intuitive, so please make sure you know the equivalents beforehand. Okay, looking at this TNM staging classification, the higher the figures next to these letters, the worse the case. And then, as an example, T3N2MO, this is the breast cancer. This stage would be called third A stage, which means this is a big tumor, 2 lymph nodes are engaged, and 0 metastasis. And the second example, T1NOM1, you see the figures are not so high, but 1 metastasis dramatically changes the situation, because it's already the 4th stage of cancer, which means the metastasis is far away from the initial tumor. For example, liver. With the primary breast cancer, liver is considered a distant organ. That's why it's 4th stage of cancer process. Now moving on to therapy. There are different types of it, systemic and something which is done locally. For example, surgery, we can remove the lesion, or it could be radiation therapy. These are very big, expansive areas of medicine. So many complex ideas, notions, everything. I would never say I know these areas well. With radiation, it's already so advanced now. They have these knives, all types of approaches, sophisticated, cutting-edge approaches. They are really complex. I do not know a thing about that, to be honest. Let's move on to systemic therapy. Depending on which type of medicine we give to the patient, we can say we are dealing with chemotherapy, immune therapy, targeted therapy, or endocrine therapy. Well, when we speak about systemic therapy, it's something which we know a little bit about. Before we look into the subtypes of this therapy, we have to say there is another classification. For example, neoadjuvant therapy and adjuvant therapy, depending on the clinical protocols and type of cancer. A patient might get their medical therapy or drugs before surgery, and that would be neoadjuvant therapy, or postoperatively, and that would be adjuvant therapy. When we have the 4th stage with metastases, we would start talking about the lines of therapy, 1st, 2nd, and up to 4th. It depends on how much money and livelihood they have, actually. When we deal with systemic therapy, we have to somehow assess the efficiency or efficacy of the medical treatment, whether we stop the disease, whether we see regression, or vice versa. You see the system which allows just that, RECIST, response evaluation criteria in solid tumors. And I would note here that solid tumor is actually named solidные опухоли. which is not typical. The stress on the first syllable in the word solidny is not typical for Russian, but still we have to be correct about that. So back to the classification. We might have, after therapy, we might have complete response, which means the tumor disappeared, partial response, it shrinked, stabilized disease, which means the tumor stopped growing. Progressive disease means everything is not, everything we are doing is not working at the moment. The therapy is not efficient. Progressive disease is something really sad. Yeah. Okay, now based on the type of drug we choose for therapy, there has always been chemotherapy. It's the very first type of treatment that emerged historically. Chemotherapist is the oncologist that specializes in choosing the best drug for the cancer patients. Let's move on. Endocrine therapy. Here we have to focus on the type of tumor, whether it be hormone sensitive or insensitive tumor. It's usually about breast cancer or prostate cancer. The next type is targeted therapy. Based on molecular testing, we can identify the target and we can choose the drug that affects this target. Here we have to mention monoclonal antibodies drugs, and usually their names are ending with UMAB. It's so interesting. And recently I've posted on my Telegram channel the classification of names for drugs based on which you can identify the target cells and so on. Next type, TKI, which stands for tyrosine kinase inhibitors, and these drugs are usually ending in inib. In a lot of conferences, we can hear when they speak about immunotherapy, they usually speak about control point inhibitors. These drugs are targeting immune system, but there are also other types of drugs, immunomodulators, vaccines, cell-based immunotherapy, oncolytic viruses. But these checkpoint inhibitors are the most common, and everyone is using them nowadays. Thank you very much for attention. I hope it was useful for you as practitioners, and I wish we all face these words only and exclusively in our work environment. Otherwise, you are colleagues with Anya, and you can ask advice from me through her if you need. I wish you didn't need that. Thank you so much, Dmitry and Anna. I'm sorry for interrupting our speakers, and I am doing that to have Q&A session. Did you enjoy that? Do we have any questions? At least someone understood a word from this presentation. That's good. I understood very little, but my question is as follows. In medical interpretation and translation, do we have this trend? Do you see the trend? When the old post-Soviet or Soviet terminology is forgotten and the new English-based terminology is used in our linguistic environment. Yeah, that's the trend we see. I work in medical conferences, and I see that our speakers who often travel for work and travel to other countries for conferences, they use so many foreign acronyms and terms even when they speak here at at home, actually. Yes, I also agree. There are a lot of words that are just adopted, and that's it. The term we mentioned at the beginning of the presentation, pathologist, that's what we say among us, the professionals. And FISH, fluorescent in situ hybridization, that's too long. Or IHC, immunohistochemistry, or sequencing, next generation sequencing, and so on. We, the professionals, do use these English acronyms and terms profusely. Okay, right. Do we have a question? I'm sorry, maybe I just missed it. Diagnostic methods. I heard intraoperative diagnosis or diagnostics. The native speaker called it frozen somehow. I could not understand. So the native speaker said frozen, whereas it was intraoperative diagnostics. Is it the same or not? Okay, intraoperative diagnostics, what is it? It's when you have your patient on the table in operative room, operation room, and you still cannot understand whether it's malignant or benign tumor, or you do not know the status of lymph nodes, and you do not know how far you should go with removing the nodes and the tumor. And while the patient is still open, you send the tissues to the lab for testing. Yes, that's true. They often call this frozen term, or they might call it express histopathology. This might be used as a synonym. Intrasurgical, intraoperative, frozen sections, tissue sections. Something like that. That's true. These are equivalents. Thank you. Any other questions? Thank you so much. I was listening carefully, was trying to memorize and make notes. So my question is, actually I have a couple of questions, and they are all about translation. At the beginning, you said about the inconsistency of terminology between English and Russian or Ukrainian. We often have lack of equivalent in Russian and Ukrainian. So what do we do about that when you translate a document from English and you find absolutely nothing similar in Russian or Ukrainian? What do we do? Do we use this English term, just transliterating it in Cyrillic, or what would be your advice? That's my first question. My first question was for Anya, and now for Dima. I'm asking you to be honest. When you were listening to interpretation of conferences, what did you listen more carefully? Did you listen to Anya's interpretation or the original sound? Okay, let me reply first. When you are in a interpretation setting, if you are in a booth, it's okay. But if you are doing consec, and you are surrounded by the doctors, you always can ask and you can make it comfortable for them. But when you are working at home at your desk and doing translation, there is no other option. The best option would be to have kind of communication with the professionals and with your colleagues, of course. I did not, I'm sorry, my turn to reply. Which conference did you mean? You said you were listening to Anya's interpretation of a conference, medical conference. Okay. I was not at home. I was at the conference, but in the next room. Okay, anyway. I was listening to Anya's interpretation, and I didn't hear any nonsense. Everything was fine. both the speaker and Anya did well. Let me say it like this. A couple of years ago, I was not listening interpretation at conferences. I just didn't think about that. When we had our conferences about lab diagnostics, I was sometimes asked by my superiors to listen to interpretation and assess it. I did it twice, and both times it was very bad. Then we started inviting Anya, and she did well. I would never say that there is 100% coverage of a speech. You could never render every single notion, every single word, but that's not critical. What's essential is there is no distortion in the meaning of what is said. I sometimes hear an interpreter speaking like a machine gun, with a high pace, but the sense, the meaning of what is being delivered by the speaker is distorted. It's actually not what they meant. And I look at the audience, and their faces are kind of lost. They look lost, and that's bad. Now, during the pandemic and the lockdown, we had no conferences, but from now on, I tend to listen to both the speaker and the interpreter whenever I attend a conference. Yeah, that's true. You can never render every word. When we talk about medical conferences, usually doctors speak with high pace. They speak fast, and the quantity, the number of meaning units is really high. But what's good for us is that the speakers tend to repeat what they said for the first time, then they do it once again and then again. So we will have plenty of time to deliver the message correctly. But we have to make sure we never distort the initial message. And you have to be able to identify what can be lost in translation and what cannot. Now about translation and interpretation. Who listened to our interpreters? What would you say? Do you remember the moment that we switched to the Q&A session? The interpreters, our interpreters, actually had the presentation, this presentation, but in Q&A you can never know what's going to be asked, and this is the critical moment. Okay, any other questions? Yeah, that's true. When a speaker listens to a question about things that they have never said, that's something confusing. Q&A is actually the best way to assess, to estimate the quality of interpretation. If the questions are irrelevant, this means the interpretation was bad. Thank you. That's not a question I'd like to voice. It's a comment. Yeah, about missing something in translation. That's true. That's true, but that's not needed. 100% can never be and should not be rendered. I would like to say that you initiated a very good thing. And my question, or rather a wish, would be, could we consider this an initiative, a start for something which could be done for other subject areas, not only medicine? And now to your medical topic. You are a wonderful duet. You are an interpreter and a medical professional. I'm sure this initiative could be beneficial for both sets of professionals. Why did we decide to do that? Because at one of the conferences I worked at, I saw something similar, but these people were an interpreter and a legal professional, a lawyer, and that's why I decided to do this. So now Natalia Fedorenkova is typing in our chat box in online streaming that oil and gas would be a nice thing to talk about next year, maybe.